Well, thank you very much for inviting me. It's a great pleasure to be here in the Kingdom, which I always find incredibly welcoming and feel part of one of you. And it's a reflection, I suppose, of the amount of collaboration that we have had over the years. So I really thank you. And I also thank EBMT for proposing me to be here. So my talk today is going to be an overview of the advances that have occurred in the management of thalassemia, both with conventional transplantation and gene therapy. Those are my disclosures. And so thalassemia, as all the other hemoglobin disorders, has its manifestations in relation to the switching on the globin chains. And this gives us an opportunity not just to change the actual stem cells and produce novel erythropoiesis that has a normal hemoglobin production, but actually to manipulate that switching, which is what we do with gene editing. As you know, the change of the gamma chain leading to hemoglobin F production onto adult hemoglobin with the beta chain production is controlled by the gene BCL11A that leads to the repression of that gamma chain production, and we now have the ability to switch that off, as we will discuss a little bit later. But let's start with thalassemia itself. The alpha and beta chain imbalance caused by the different mutations leading to this condition leads to ineffective erythropoiesis. As a consequence of that, there is not just anemia, but there is iron overload because of the disruption of the hepcidin axis. And so we have patients where there is organ damage, both by the iron loading and the anemia caused the disease, but also by the treatment that we provide. In addition, there is marrow expansion and bone disease, extramedullary hematopoiesis, peripheral hemolysis, causing gallstones and a hypercoagulability state that leads to further endothelial damage. And so we truly have a systemic disorder, which is not always well recognized in the context of thalassemia, unlike in sickle cell disease. Now, the survival of patients with the availability of transfusions and chelation treatment has improved substantially since the 70s when that was introduced, and you see that reflected in the improvement between the red and the green lines. But we have recently looked at this very carefully in two European countries where there is centralized healthcare systems. One is Cyprus and the other one is England. And despite of the initial promise of the oral chelators and the availability to be able to target the chelation treatment with MRI techniques, the reality is that there is still a significant reduction in the overall survival of these patients. And you see that in Cyprus, there is a 15% reduction against the general population in the modern period of care. And in the UK, there is a 5 times greater chance of mortality in comparison to the equivalent general population. In fact, it's not just a matter of survival, but of morbidity. And although many of these patients grow into the 40s and 50s, the reality is that there is a very substantial burden of care. And what you see there is data from the National Hemoglobinopathy Registry in England. And so that encompasses all the patients and has been analyzed between 2009 and 2018, so a modern period of care where there was good chelation availability and the use of MRI T2 and ferret scan nationwide. And despite of that, after 25 years of transfusion treatment, over 90% of the patients have at least one organ affected, and often multiple organs, so that 40% of the patients have endocrine complications, 40% of the patients have osteoporosis with fractures and pains, a third of the patients have diabetes, and at least 1 in 5 patients have cardiac disease, half of them with arrhythmias and half of them with heart failure. Now, in comparison to that, we have the ability of correcting this disease with conventional bone marrow transplantation, of which Lucarelli and his deputy, Emanuele Angelucci, who is the new Hemoglobinopathy Working Party chair, were fundamental in being able to introduce the technique. And some of you will be aware that it is ion control what determines the outcomes best in the context of the traditional busulfan cyclophosphamide chemotherapy regimens. And so patients can be stratified according to whether they start the chelation early in life in the treatment, whether they had the chelation done regularly, whether it's portal fibrosis, and whether it's hepatomegaly. Now, the second thing to realize is that actually transplantation not only achieves a cure of the disease, but actually improves quality of life. And so what you see there is data from the Italian registry that clearly shows that, of course, the intensity of the transplant procedure leads to a reduction in the quality of life in the initial period. But if you were to measure the situation of these children a year and a half post-transplantation, they actually have regained a quality score which is indistinguishable from the general population unless they have developed chronic graft-versus disease, which is those who are dropping off in that graph. And so the approach to transplantation for thalassemia is very different than that done for hematological malignancies, in that even in the fully match-related setting, there needs to be an element of prevention of GVHD with serotherapy. And long term, we now have data of over 30 years comparing patients who have been transplanted against those who continue transfusion and chelation treatment. And despite of the fact that the majority of these patients were done with double alkylated agents, they actually, as you can see in the blue bars, had better quality of life than those who continue with conventional treatment, particularly in role limitations. So this is the ability to maintain a job, bodily pain, and emotional functioning, which is the ability to maintain a partnership with another person, despite of the fact that many of these patients, because they have received BUSI, will have been infertile. Now, there are a number of things that we have learned, and that is that expanded ineffective hematopoiesis puts the patients at risk of graft failure. And very much as the discussions that we were having a few moments ago about sickle cell disease, that can be quantified with MRI techniques, and we have adopted a number of strategies to be able to minimize this. And so we use hypertransfusions or hydroxychloroquine combined with azathioprine, or we add thiotepa, particularly to those patients who are of a young age. The greatest development in the last 15 to 20 years has been the adoption of fludarabine-based conditioning regimens. This was pioneered by Franco Locatelli and his group in combination with triosulfan and thiotepa, and that led to a very substantial reduction of toxicity. What you see in those graphs is that in that context, unrelated transplantation is not significantly different than related transplantation, and that the old classification according to the iron load of the patients seems to disappear in relation to the amount of events. Something that does not happen when you use busulfan, where there is still a significant difference between class 3 and the rest of the groups, though with the use of fludarabine and busulfan, class 1 and class 2 have similar outcomes. We went further and adopted the FTT strategy, but added serotherapy even in the context of related transplants. And that, of course, that leads to a greater risk of a stable mixed chimerism, but does have very low graft-versus disease. And so the 58 patients that we have done over a 10-year period leads to an event-free survival, or disease-free survival of around 93%, as you can see, with very prompt engraftment of around 12 days, and low rates of graft-versus disease of around 10 to 14% for acute GVHD, and a chronic graft-versus disease rate at 18 months of less than 2%. And that is by adding the use of a form of ATG or alemtuzumab, preferably Fresenius, because it has a shorter half-life and leads to less unstable hematopoiesis. And so the price that we paid is that, of course, only half of the patients achieve full donor chimerism in both the myeloid and the T-cell fraction, but this remains stable over time and leads to disease correction. Now, real-world data is now available from both EBMT and CIBMTR, and they are able to determine what are the most important factors for the long-term effect of these transplants. And interestingly, age has been the most important of these factors, with optimal transplant outcomes up to 13 years of age, particularly in the younger patients. And so what this is telling us is that we need to make bone marrow transplantation part of the treatment algorithm of these patients from the moment of diagnosis, and not to leave transplantation for those desperate cases where otherwise the chelation treatment is not going well. Indeed, CABNTR has done the same analysis, like with EBMT, of over 1,000 patients, of which 2/3 were related patients and the rest unrelated patients, and they have encountered exactly the same. That age is the most fundamental determinant, with best outcomes up to 6 years of age, but very good outcomes up to 15 years of age. The second important factor is that in a modern setting with molecular typing and the use of fludarabine-based regimens, there is no difference between HLA-match-related and HLA-match-unrelated donors, unlike sickle cell disease, so that a greater number of patients are able to be cured with conventional transplantation. Whereas there is a problem of graft failure the moment that you start to introduce mismatched donors. And in the setting of fludarabine-based therapy, so not combined with double alkylated agents, there is very comparable cure rates with both busulfan and triosulfan for those of you who do not have triosulfan available in your countries. However, there is a lower toxicity when you use triosulfan, although there is probably also a slightly higher risk of secondary graft failure. And this also yet again identified that it is age, that of more than 10 years of age, and the use of mismatched donors, which are the factors associated with increased mortality and reduced long-term engraftment. Now, in my center, we have been working with the Johns Hopkins group to try to see whether we can apply a reduced intensity haploidentical protocol to this disease in the same way that we did for sickle cell disease. Cleveland Clinic and Vanderbilt Group also contributed a number of patients to this work. And so when we started trying to replicate what Molagios Meade had done, we found exactly the same as then, that 50% of the patients rejected the transplant. However, if you add either thiotepa or tibia, it is possible to reduce that graft failure rate to somewhere around 10%. With risk of graft-versus disease that, as you can see, is very acceptable, of somewhere between 20 to 30% in what it constitutes a haploidentical setting for an otherwise complex disease to undertake haploidentical transplants. We haven't been able to identify long-term differences between either use of TBI or 400 TBI or thiotepa, though if you look carefully at the bottom, you can see that the event-free survival appears to have a trend towards being better in the 400 centigrade group with a better overall survival, and that is the arm that we are currently adopting. However, it is from the countries in Asia, from Thailand, and India, where I think the most exciting modifications to our protocol are coming and may be able to reduce further the graft failure rate and improve outcomes by minimizing graft-versus disease and any other alloreactive complications. And this constitutes the adoption of post-transplantation immunosuppression. So this is 2 cycles of dexamethasone and fludarabine previous to actually undertaking the transplant, and the adoption of abatacept, which, as you know, is now FDA approved, both for stabilization of the graft and to minimize graft-versus disease, given regularly until at least day plus 100. Now, I want to finalize the conventional transplant part of my talk by giving you a word of caution in relation to unstable myeloid chimerism and poor graft function, because I don't think this is specific to sickle cell disease or gene therapy or the use of hydroxychloroquine. We have looked very carefully at our last 65 patients with thalassemia, and we have identified 3 cases in whom there has been MDS AML, all of them with deletion 7 involved, and presented somewhere between day 60 to day 200 in the context of poor graft function and myeloid chimerism that was rapidly decreasing below 50%. And so it is essential that we are able to optimize our protocols to stabilize the graft function, and hence the use of post-transplantation immunosuppression, pre-transplantation immunosuppression in the haploidentical setting. Now I'm going to now move on to giving you an overview of the 2 strategies that exist for gene therapy. The first one is that of gene addition. So this is the Bluebird Bio product, Beticel, by which a functional hemoglobin is integrated with the use of lentiviruses, and this is the data of the long-term follow-up study. As you know, gene therapy patients need to be followed up for a minimum of 15 years as requested by the regulatory authorities. And so the data I'm presenting you here is when the patients have completed the first 2 years and they have enrolled in the long-term studies, either from the original phase 1, phase 2, or phase 3 studies. And this constitutes data on 32 patients. Now, the phase 1, phase 2 patients didn't have the product optimized, and so didn't achieve the good hemoglobins that the phase 3 have achieved, and so we have to be careful when looking at the data from that point of view. However, following 2 years of infusion, all patients have remained alive at last follow-up, and there have been no vector-derived replication or any transplant-associated complications. Those adverse effects that have been reported have been in relation to previous damage caused by the disease, like, for example, gallstones. And the transfusion independent, as you can see there, is durable. And so the moment that you have the dark blue lines, it means that the patient has remained transfusion independent. And so in the optimized product, in the phase 3 study, 90% of the patients remain transfusion independent, whereas in the previous product, before the manufacturing improvement, which was selecting a bright CD34 population with vector integration, only 2/3 of the patients were being cured. And you see in the continuous line what is the total hemoglobin of the patients, which is within the normal range, of which the majority, as you can see in the continuous blue line, is constituted by the new this continuous line is the total T87Q hemoglobin that was integrated in the genome of the cells. And that allowed an improvement in the erythropoiesis, and whether you look at it by measuring the soluble transferrin receptor or looking at the trophon biopsies, you can see that the hypercellularity, the expansion of the hematopoiesis, returns to normality with a normalization of the ME ratio. And that is linked to the fact that you are able to reduce the ion burden either by venesections or the use of chelator agents, so that you do not leave ion in the organs of the patients that might cause long-term harm. Now, an alternative approach is what I was alluding to you at the very beginning, and is the cause of indels or insertions of deletions in the erythroid enhancer of BCL11A in order to inactivate it, so that hemoglobin F gets reactivated. And there are potential benefits of doing this approach in that you are not randomly integrated anything into the genome, and it may well be that that is a safer way of dealing with this disease. And so I'm going to present you here the 111 part of the Vertex trials, which accrued patients between the age of 12 and 35 who have been transfusion dependent for a minimum of 2 years. And so one of the benefits of doing gene therapy in thalassemia is that we are able to mobilize these patients with the use of GCSF and plerixafor, unlike in sickle cell disease when one can only use plerixafor. And so very substantial number of cells are able to be harvested, to be edited ex vivo. Neutrophil and platelet engraftment is later than you will expect for an autograft procedure, and that probably is a reflection of the fact that the cells have been in the laboratory being dealt with. But the actual period of neutropenia is not substantially increased because the patients are only conditioned with busulfan, and they don't become neutropenic until around day 7 or 8 post-transplantation. So far, there have been 44 patients who have received exa-cel, and 42 of those patients are transfusion independent, with the 2 patients who haven't achieved that point having reduced the amount of blood use between 75 to 89%. And patients who have received exa-cel achieve a normal hemoglobin level somewhere around 3 to 4 months post-transplantation, of which the majority, as you can see in that graph in dark blue, is hemoglobin F, and that is stable over time. And indeed, not only that hemoglobin F is pancellular, so it is in the majority of the stem cells of that bone marrow and is stable over time, but when we look at the editing, whether it's in peripheral blood, at the bottom on bone marrow at the top, you can see that there is a dropout, that we are really dealing with very early stem cells, which so far they appear to be able to provide normal hemopoiesis long term. And the safety profile is consistent with that of busulfan malablation. There have been 2 cases in the thalassemia arm where there could have been serious adverse events related to the actual product, but not because it was proven, rather than because we couldn't exclude it. One was a patient who had thrombocytopenia for quite a few months, and the other a patient who developed macrophage activation syndrome with idiopathic pneumonia syndrome, who was under my care, but both patients are transfusion independent and well at present. There has been 1 death in the sickle cell arm around 8 months post-transplantation in a patient who got COVID, although there may have been an element of busulfan lung damage. But overall, I hope I've been able to show you that age is the major determinant of transplant outcomes in thalassemia, that unrelated transplantation offers a long-term equivalent solution to patients with sibling transplantation in this disease. And so that you shouldn't be afraid of restricting conventional transplantation to those who have a related donor. That haploidentical transplantation is feasible and addresses the poor donor availability, and that we're starting to address the remaining challenges of GVHD and graft failure with the adoption of pre-transplantation immunosuppression and abatacept. However, there is no doubt that this early identification and incorporation of transplant techniques in the overall care of these patients, who is going to enable these patients to be cured at an early age and to grow into adulthood without organ damage. And now we have the possibility that a form of correction of the patient's own cells may offer us a solution without having to take the risks or more complex or mismatched transplants. So thank you very much, and I'm very happy to take any questions.